Yes, another Puscast, a review of the infectious disease literature, this one covering the last 2 weeks of April in the year 2018. References, as always, are at edgydoc.com, plus you can probably Google it and find it if you're really interested. Before we get started, I will note that there's a petition to have the Infectious Disease Society of America stop sending the clinical infectious diseases and the Journal of Infectious Diseases in plastic bags. They make nearly 500,000 plastic bags a year. And I'm sure if you're even dimly aware of the environment, what plastics like that are doing to the oceans and the land. Our children and grandchildren are going to inherit one shithole of a world, and maybe the IDSA and infectious disease docs can do a little bit to help make it just a little bit less of a shithole. The one thing I've learned doing my podcasts, etc., is that if you do a little bit spread out over time, a lot can be done. So I heartily recommend that you wander on over and sign the petition. The IDSA says that it will cut into their profits by not using plastic bags, so they obviously don't give a rat's ass about our children's future and prefer to continue to line their nests. I mean, it's not like they're GM or anything where they're making a product and have stockholders. They're supposed to be making the world a better place, not spewing out 500,000 plastic bags a year. In the meantime, I'm going to send the plastic bags back to the Infectious Disease Society of America so they can reuse them for future mailings. I figured they'd be happy to recycle them that way. But you're here for the medical literature, aren't you? So let's move on to the endlessly fascinating world of infectious diseases. Death from infections is not uncommon in Africa. And this study looked at giving twice a year azithromycin to basically every kid and versus placebo, and saw what happened to mortality. And what happened is kids who got antibiotics twice a year were in a group that had 14% overall decrease in mortality. That's pretty impressive. You would expect that would be a great way to breed resistance in a community, and they did not specifically look to see if that happened. But then that's always the trade-off of infectious diseases. You save someone today at the long-term cost of being unable to save them tomorrow because of resistance. But still an interesting way to decrease mortality in Africa. Now all these kids can all grow up to get asthma. And as long as we're on the topic of antibiotics, there was a series of 23 cases of elderly patients who developed acute kidney injury while receiving high doses of cloxacillin, which is a anti-staphylococcal penicillin. They found it was related to high troughs and suggest that perhaps drug monitoring of drug levels would decrease the toxicities. I suspect we don't do enough monitoring of drug levels in infectious diseases, mostly because it's not practical to do in an expeditious way. And then there's an interesting review called Busting the Myth of Static versus Sidle, a systematic review of the literature, where they basically point out that for infections, it doesn't make a difference whether or not the antibiotics are static or sidle, but more important is probably the pharmacokinetics of the drug. I never actually thought that it made a difference with the exception of 2 infections, meningitis and endocarditis, both infections where, at least early on, there's not much immune system to help out in eradicating the organism. And I think I would be loath to give neutropenic febriles static antibiotics. So I never thought it was important whether or not patients got static or sidle antibiotics. That being said, outcomes with infectious diseases always are determined by the virulence of the organism, the efficacy of the antibiotic, and the competency of the host immune system. And if you have a virulent bug in a patient with not much of an immune system, or you can't get good source control, which is the same thing, I would err on the side of a sidle drug. And I'm still going to give sidle drugs for meningitis and endocarditis. They do talk about those particular diseases in the article, and I would be leery, even though the data to support using sidle drugs is surprisingly thin gruel. So as always with a given case, I'll overthink it, and whether or not I give a sidle or static will depend on how much I overthink the case. Personally, I always think it's important to consider when deciding on a specific therapy how close an individual patient is for being represented in the trial by which you're using to determine the therapy. And boy, that was a convoluted sentence. But the ID literature is always annoying because they never really stratify patients by risks, bug, and drug. So, God forbid, I actually have to individualize sometimes. Ugh, I hate saying that. Never drink raw sap that's been contaminated by a bat. A good rule, because that's how you get Nipah virus. Not obviously a problem here in the Great Pacific Northwest. However, there is also, interestingly, an association between temperature and Nipah virus. In humans, with cooler temperatures being associated with more Nipah virus, because perhaps the virus survives longer in cooler sap. Longtime listeners know I have a fascination with the weather and infectious diseases, agreeing with Mark Twain that everyone complains about the weather, but nobody tries to do anything about it. There's a new Japanese/sushi bar just opened up near my house. Hog heaven. But I suppose I should be careful with the dry seaweed. It turns out in Japan, they've had at least 7 outbreaks of norovirus due to contaminated nori, i.e. dried seaweed. Noro often ends up in salt water, which it survives quite nicely, and if it gets in the seaweed, it isn't eradicated by the drying process of nori, and they've had a little over 2,000 cases of norovirus traced back to seaweed. I'll tell you, it's not going to stop me from eating sushi. What doesn't kill you makes you stronger. I know the whole purpose of healthcare in the United States is not to give it to people, and if you do give it to people, make sure it's really expensive. I was in overnight this year for small bowel obstruction. Let's just say Broccoli and I did not get along very well that day. Total bill, about $10,000. But there are benefits to giving people access to healthcare. In the Netherlands, they have given unrestricted access to hepatitis C therapy in men who have sex with men. And guess what? As a result, hepatitis C virus incidence has been declining in that population. Give people good health care and their health gets better. What a concept. And just a reminder that hepatitis E can cause chronic hepatitis in immunoincompetent patients. Most of the cases I remember have been in transplant patients, but this case report is a chronic hepatitis E in a pregnant woman who was on infliximab and azathioprine. I suspect we may be underdiagnosing hepatitis E, at least here in the Great Pacific Northwest. I usually don't talk much about kids' diseases, as I'm an adult infectious disease doctor. It's who I treat, not how I act. But there were 4 articles on the rotavirus the last couple of weeks. The rotavirus, as you know, is a derivative of the Mary Tyler Moore virus and causes diarrhea in children. One, and no surprise because it's a wild-type virus, you can find vaccine virus in the stool specimens of children after they get the vaccine. So if you're trying to determine efficacy and a kid presents with rotavirus diarrhea, you can't tell whether or not it's the vaccine or wild type unless you do very specific genotyping. There is a phenotype of human beings that are less likely to get rotavirus infections. To quote the article, quote, increasing evidence suggests that susceptibility to infection with specific RVP genotypes is associated with HBGAs, histo blood group antigen, determined by secretor status and Lewis phenotype, controlled by the FUT2 and FUT3 genes respectively. They then go on to talk about the specific biochemical pathways, which I will remember in less time it takes for me to read it. Suffice it to say, all people are not equal in their susceptibility to rotavirus. The good news is that, at least in Bangladeshi children, the vaccine is equally protective in kids with or without these particular phenotypes. However, it's a live virus, and when correcting for the effectiveness of the vaccine on the basis of whether or not they were secretors, it turns out that the vaccine is less efficacious by about half in that population. So the vaccine is less efficacious in those who are more innately resistant to rotaviral infections, which is interesting. The big worry about the rotavirus vaccine has been intussusception. In this New England Journal article where they looked at the rates of intussusception in children in sub-Saharan Africa, they found that the rates were no greater than background. casting doubts as to whether intussusception is a complication of the vaccine. So the newer vaccine would appear to be safe, although I've never quite understood how the viral vaccine could result in intussusception. And then the MMWR has a description of 3 rotaviral outbreaks in California. 2 were in child care centers, but the 3rd was in an adult assisted living. One wonders, with the use of the PCR panels for diarrhea, if we will be diagnosing more rotavirus in the adult population. But it's still present in outbreaks despite the use of the vaccine. When you think of Missouri, at least as an infectious disease doctor, you should think of the Heartland virus. It's a virus spread by tick bites, and most of the case reports of this virus have come out of that state. There's another case report in emerging infectious diseases of a case of Heartland virus, and the patient went on to develop hemophagocytic lymphohistiocytosis and died, and was found to have Heartland virus. A study out of Nigeria suggests that patients who are infected with HIV virus subtype G have more neurocognitive issues on neuropsychiatric testing than those with the CRF02AG strain of HIV. This was in heart-naive patients. When you look at the data, the 2 that were most statistically significant were those for speed of information processing, 0.002, and executive function, 0.001. But none of the rest are really statistically significant, and they looked at 8 different domains in only 124 people. I don't know. It's my understanding with statistics that if you look at a small number of patients, you're going to get a lot of outliers. So I'm not enthusiastic that this is a valid study, although statistics, as always, makes me like Mr. Gumby and makes my head hurt. Though this wouldn't be the first time it was suggested that HIV does cause a decrease in neuropsychiatric function, and I would not be surprised if that were true. I'm just not certain with my minimal understanding of statistics that the conclusions are as valid as one would like. But that's also would be like me talking what it's like to dunk a basketball. I'm 5'8". I can't get anywhere near the rim. In another quick case report of Rickettsia connori causing purpura fulminans in 2 patients in Israel. They note that the other 2 Rickettsia associated with purpura fulminans have been Rickettsia rickettsiae and Rickettsia indica. Rickettsia were not in my differential for purpura fulminans until today, but you probably already had it on your differential diagnosis. In my long and storied career, I've had a couple of cases of disseminated Bartonella Hensley that were seronegative but had positive PCR. This diagnostic problem is emphasized in this study in emerging infectious diseases, where they took patients with suspected Bartonella Hensley who were seronegative and found that 8% had a positive PCR. So if you really suspect Ted Nugent's disease, cat scratch fever, you want to get a PCR and a serology. Both of my patients were renal transplant patients, which may have affected their ability to develop a serological response. Borrelia miyamotoi is one of those hot new Borrelias in the world. It's a tick-borne illness found pretty much wherever you want to look for it, unlike, say, Lyme disease. 2 things are interesting in reference to Borrelia miyamotoi. 1, the C6 peptide test used for Lyme disease cross-reacts with Borrelia miyamotoi. In 22 cases, 24 cross-reacted. That's 92%. So obviously we need a better test to distinguish Borrelia burgdorferi from Borrelia miyamotoi. And a study out of Russia shows that the organism can be found in the blood for only a very brief period of time by PCR. Roughly the first 8 days of illness, although it could stretch out to 30 days, the vast majority had it in the blood for 8 days and then it rapidly tailed off. So the PCR in the blood is of limited utility, and the C6 peptide cross-reacts with Lyme. So really we need a better testing modality for this organism. You can't tell in real time whether I'm coming or going, but I just got back from basting my lamb. I have a leg of lamb on the smoker with a Worcestershire tomato-based barbecue sauce. It's going to be a fantastic dinner tonight. And no, you're not invited. I don't ever deal with tonsillitis or pharyngitis. I do inpatient adult medicine. But some of you may not be that lucky. This study was a meta-analysis of antibiotics for recurrent pharyngotonsillitis and found that clindamycin and amoxiclavulanate were superior to penicillin for preventing recurrence of strep throat, basically. Although they thought the studies had a, quote, high level of bias, unquote. I just put that out there for your own bemusement. When I get asked by house staff what to do about sore throats, I usually shrug my shoulders. Ask me about MRSA endocarditis. That I know. Some things boggle the mind, or flabbers my gaster. I would think there'd be nothing simpler to treat appropriately than gonorrhea. It's 250 of IM ceftriaxone and a gram of azithromycin. The guidelines are clear-cut. That's the only option. Guess what? 20% of the time, people don't follow the guidelines. It was more common that they didn't follow the guidelines in private practice, but even STD clinics got it wrong 10% of the time. It always amazes me what a crappy job doctors do with the basics of medicine. And then we bitch when people regulate us. Hell, we can't do it right. What do you expect? Especially for simple things like gonorrhea or UTIs. I remember about 15 years ago, we did a quick survey of treatment of cystitis in young women in the childbearing years. I think we looked at 20, 25 patients real quickly, and not a single one got the same prescription. There was zero uniformity. Boggles the mind. But I guess if we're treating a bunch of unique snowflakes, they all get their own therapies, right? There was a prior study that showed that invasive Staph aureus infections are more common in the poor. This study confirms that. But not only do the poor more likely to get MRSA bacteremia, it was, quote, strongly associated with county-level antibiotic use. So not unsurprisingly, widespread use of antibiotics increased the rates of MRSA bacteremia, probably because it increased the rates of MRSA carriage. And if you're newly colonized with MRSA, you have a high chance of invasive disease in the subsequent year. One would wonder how many of those antibiotics were appropriate, though I wonder how the poor afforded their antibiotics. When people get colonized with pathogenic organisms, the question is always how long are they likely to carry it? In the case of ESBL E. coli and Klebsiella, this was looked at in a study out of the Netherlands, and 33% of colonized patients continued to carry E. coli and Klebsiella up to 8 months. Although at the same time in the study, 12% picked up a new strain when they were prior negative. I'm still immensely skeptical that you can do anything about the acquisition of normal human flora, except, of course, for good adherence to hand hygiene. But it's safe to say that if you get colonized with an ESBL E. coli or Klebsiella, it will probably last longer than the average Trump cabinet member. And as long as we're on the topic of GI pathogens, one, Vibrio parahemolyticus illness has been going up in Spain, and it's because the oceans are getting warmer, so they're seeing a marked increase due to a single clone of Vibrio in the waters of Galicia. That's been a consistent finding over the last 15 or so years. The waters of the Pacific Northwest have gotten warm enough to support the growth of Vibrio species, and now they're found in oysters and have caused outbreaks. The waters of the Black Sea have been warming, and as a result, they've seen more Vibrio infections there. And now we have Galicia, Spain. The diarrhea in Spain is not mainly on the plain. It's on the coast. The second thing of interest is there's been an ongoing outbreak of Salmonella Newport that's linked to ground beef. And thirdly, they did a study where they had people deliberately take Campylobacter, to see if rifaximin could prevent the illness. It couldn't. I don't think I would volunteer for such a study, although I suppose someone has to do it. For me, giving steroids for bacterial infections always seems an unnatural act. And I know the data suggests that patients get better faster, although there is some downside depending on the population looked at. But I've always been sort of uncomfortable giving corticosteroids to patients with bacterial processes. This study looked at liver abscesses in chronic granulomatous disease, and them what got steroids got better faster and needed fewer interventions. And these were mostly Staph aureus liver abscesses, with a smattering of fungal and other organisms. All the CGD patients here get treated at the university. I think I've seen one in my career. And I'm still bitter about the board question, where they had a series of Greek letters and you had to try and remember which one was the right one for treating CGD. Seriously, beta, gamma, delta, you look it up. But gods know I love to bitch about the boards. So here's a curious outbreak. And again, this reminds me with these weird cases, you need to have pronunciation guides, guys. It was a mass poisoning in Mozambique. It was due to drinking Pombe, Pombe, a traditional alcoholic beverage. And they died of what's probably about to be mispronounced bongkrecic acid poisoning, Bongkrkic. It turns out that this was due to Burkholdia gladioli pathovar cocovenimens, which I'm sure I completely botched. But this particular Burkholdia makes large amounts of bongkrecic acid and was found in the Pombe. So a peculiar Burkholdia makes an unpronounceable toxin that leads to a large number of deaths from diarrhea, vomiting, general malaise, then psychomotor agitation and abnormal posturing, and death. Just a reminder that not all group B strep are the same. I've talked about the group B streptococcus serotype 3, sequence type 283, that is a foodborne illness that is a problem in Asia. It's found in some of the foods. People then eat the foods, predominantly freshwater fish that are eaten raw. They get this group B strep that causes sepsis in normal people. It also tends to go to prosthetic joints and often leads to debridement and joint loss. This is a more virulent group B strep, maybe, compared to the standard group B streps. But again, unlike most group B streps, this is obtained by eating raw freshwater fish in Asia, not only causing sepsis, but prosthetic joint infections. Between that and the contaminated nori, sushi is looking increasingly unappetizing. How many days should you treat community-acquired pneumonia? Well, the guidelines say 5, and if the patients are really sick, maybe 7, but 5 should suffice for most. The worst part about evolution, well, the two worst part about evolution from my perspective, is one, we evolved away from a tail, which I think would be very handy for scratching that place right between my shoulder blades. And the other problem with evolution is it gave us 10 fingers, and consequently that seems to be the preferred duration of antibiotic therapy. It certainly was in this study where they looked at the duration of antibiotics in patients with uncomplicated community-acquired pneumonia and found that the median length of therapy was 9.5 days. Let's call it 10. I've noticed that even when guidelines say 5, people have to go with 10. We got 10 fingers, damn it, we have to use them. Should I ever lose a hand in a tragic garbage disposal accident, perhaps antibiotic use in my hospitals would go down. And a study that shows that patients who get hospitalized for community-acquired pneumonia are more likely to have vitamin D levels that are low. I just find the whole vitamin D and infection risk to be interesting and like to mention them when I run across studies. The final thing, which I always like to bitch about, is the risk of cardiovascular events during acute infections. And it's certainly true for community-acquired pneumonia. 15% of patients with community-acquired pneumonia developed a cardiac event, arrhythmia, heart failure, myocardial infarction, and it more than doubled the mortality. There's more morbidity with infections than just the acute infection. and the long-term cardiovascular complications are always worrisome. There was a study out of Korea that suggested that if you had an increased BMI, you were less likely to get tuberculosis, but not if you were diabetic. I find this particularly interesting because there was a hypothesis in the JAMA, 15 years ago or so now, where it was hypothesized that the metabolic syndrome, the inflammatory pro-obesity syndrome that we suffer from, is a consequence of exposure to TB and is an evolved response to tuberculosis, especially tuberculosis in pregnancy. Since the metabolic syndrome and the metabolic state of pregnancy have some similarities. I don't know if that's true or not, but I certainly find it intriguing, and if not intriguing, interesting and amusing. At least there's some benefit to having an increased BMI. I keep telling my wife, hey, I'm protected from tuberculosis. Just like I tell her I will all my cholesterol down my testosterone pathway, not my atherogenic pathway. She doesn't believe either of those. Go figure. Is aspergillus the real deal in the ICU? Always a difficult call. This study looked at the utility of the serum galactomannan, which I tend to not use because it's not as useful in patients with higher white counts, was my understanding. But they found that if patients had a positive serum galactomannan antigen greater than or equal to 1.24, that the patients often had the real deal for invasive aspergillus in the ICU. Even the occasional positive culture in the ICU is fairly rare in my institutions, but certainly causes enough hand-wringing as to whether or not you should treat it. It's certainly less of an issue with toxicities in the posaconazole era. And finally, and I like to keep to my, promise to keep this podcast to 30 minutes or less, and I'm at the 27:15 mark. I always say the most important thing a speaker can do is start on time, and more importantly, end on time. But there's a nice article in Emerging Infectious Disease this month that you should read. It's called The History of Mosquito-Borne Diseases in the United States and Implications for New Pathogens. Malaria and yellow fever, for example, used to be a big problem in the United States, but now we have chikungunya, dengue, and Zika coming our way. And with climate change and global warming, the range of mosquitoes, like many other infections, is likely to change. They estimate that dengue could be seen as far north as Montreal in one estimate, and malaria used to be here in the Great Pacific Northwest. As my wife likes to say, if you want to predict someone's future, look at their past. And our past with mosquitoes has been sobering indeed. And Emerging Infectious Diseases is just a wonderful journal in general. And free. And unlike CID and JID, it doesn't come in a plastic bag. See, I brought that right around to the beginning. Don't forget to sign the petition for the Infectious Disease Society of America to stop using plastic bags to deliver the journals. They will ignore us. I have no doubts about that. But it's always worth the effort to make the world a little better than it was when you woke up. And I'm going to send my plastic bags back to IDSA every month. Just imagine if they got 10% of the 500,000 plastic bags that they send out every year to their own office. That would be quite a response. Otherwise, references are available at my growing multimedia empire of edgydoc.com, where you'll find links to my books, my blogs, my podcasts, and my phone app. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. And this was a 29-minute and 20-second consultation with greater than 50% spent in counseling and coordination of care. Later.